Yeah, I have one thing real quick. Can you kind of talk about the center of rotation and I guess its importance in establishing that or recreating the center of rotation versus of the acetabulum versus a femur?
Of course. So center rotation of your femur is going to be a point at the center of where the cup is. If you pretend your cup was a full circle, it's the exact center of that cup is where your acetabular center rotation is going to be. Um, you can adjust your femoral center rotation wherever you want to be as far as to adjust your leg length and your offset. But no matter what, if you have that hip reduced, which you damn sure better by the time you're done with the surgery, your femoral center rotation has to go with acetabular center rotation. Is if it's out of line with that, it's not going to be a reduced cup. So um, your center rotation for acetabulum is kind of set by where your cup is, and then on the femoral side, you can adjust your head size as far as your pluses or minus, as well as your offset to adjust your leg length and the offset to match as close as you can their native anatomy, as well as you can increase your leg length if you need to make up for a leg length discrepancy, or adjust offset to either match offset or improve your stability.
Okay. And I think we mentioned a little bit earlier that if you increase your offset, you have you have a more chance of getting bursitis. But does that do anything to your leg length discrepancy?
So if you increase just offset, that does not increase leg length. That said, most stems are in a situation where if you increase the head size, so instead of going like a 0, if you go to a plus 2.5 or plus 5 or whatever your system allows, majority of the time when you increase offset that way, you're also increasing leg length.
No, okay, that makes some sense.
There are
And
some systems where the stem maintains leg length when you go from a high offset to a regular. So a high offset, your neck angle becomes a little bit flatter. Is the way I kind of think of it. It looks a little bit more like a varus neck situation. So when you do a higher offset stem, a lot of the times you lose a little bit of leg length. So you can adjust. That can be a way to increase your offset without necessarily increasing your leg length if you need it, depending on patient's anatomy.
I guess I was going to move forward into the different types of, because you just spoke about the offset, and I was just thinking, you have modular versus non-modular components. But Jay, is there anything else that you think you wanted to speak about as far as pre-op planning, as far as, acetabulum, femur?
Um, I think this is like a really good topic. And even when I'm listening to it right now, I still get somewhat confused, to be honest. I have to sit back and kind of think about changing these things. And there's been times even in the OR, all of a sudden, like you said, you have to change things on the fly. And I have to sit back and think, okay, the head size going up. So, okay, all right, this is the neck is going to be this now. We got to worry about leg length and things like that. It's so many different moving parts. But can we just like a real quick brief on this one more time? Okay. So say we have offset, we have leg length, and we have just our cup. And can you just mention almost, if we could, in almost 3 or 4 or 5 lines, just the things that you can do to change those and how that will benefit you, just so we could sum it up for our listeners. If you could, Dr. Schuett, I know that's kind of a big ask.
No worries. So you want to adjust your cup to try to match their native anatomy and try and get as close to their hip center as you can. Majority of your motion or movement as far as increasing and adjusting offset and leg length is going to come on your femur side. If you're looking at your templates, and they do this on the OID a fair amount, and you'll get it on your ABOS exam as well. So if the femoral head or the center of the femur is superior to the center of the cup, that femur is going to have to shift down to make those centers line up. So that's going to increase your leg length. If the center of your femur, or the center where your femoral head is going to be, is inferior to the center of your cup, you're going to have to shorten the leg for that to line up. If your center of femoral head is medial to the center head of your acetabulum or of your cup, your femur is going to have to lateralize or shift up to increase your offset to line up. And if the center of your femoral head is lateral to the center of the cup, you're going to have to medialize. So just think of it as a way of, when you're looking at your templating films, the center of your femur has to go to the center of the cup. And just picture what that's going to do to your femur. That's kind of the way I try to remember as far as whether you're going to increase offset or leg length. If people are looking at the video, the cup that's being, or the images shown here, the center of the femoral head is directly superior to the center of the acetabular cup. So if you do that, that is going to increase your leg length because the center of the femoral head has to shift down to the center of the cup. If that center of the femoral head was medial to the cup, it would increase your offset because the femur would have to shift lateral to get it back into a reduced position. it's definitely a complex topic that even still have to review fairly often just to make sure I get everything straight.
But it makes
Right.
sense, like you say, the femur center of rotation, it has to follow, it has to move to the acetabulum, not the other way around. You just got to remember the femur is the one that's moving, and if you can keep that in mind, it can kind of help you out on what's going to be the end consequence of it all. So,
So, so I guess like for example, we'll just kind of just throw out some cases here. So if we had a patient that had really bad coxa profunda, where the femoral head is medial to the acetabulum, preoperatively we're thinking, okay, we're gonna need to increase the offset in order to get the femoral center rotation in line with the acetabular center rotation. Is that so far? Am I correct in what we're saying?
Well, so for profunda cases, you're usually going to lateralize the acetabular center because your cup is not going to be as far medial as their native hip center is or where they've developed to. So that alone will increase your offset to a degree.
Ah, okay. So you lateralize
Mhm.
the acetabulum, and then so in cases just like we said here, where you have really bad superior lateral migration of the femoral head, pre-op we're thinking, okay, we're gonna probably have to increase the leg length, or we're gonna have to bring the femoral center rotation down to match the acetabulum. So we're likely gonna have to bring that down.
Yeah, exactly.
Excellent. Jay, I know you're over there confused and taking notes and shivering in your boots.
hey, that's all right. That's why it's the 5-year program. That is okay. But this is really how you see these questions on Ortho Bullish. You see it everywhere, and it's really easy if you know what's going on, and it can really stump you if you don't. So if you can kind of grasp what we're talking about now, it's kind of hard to miss these questions. So I'm glad that we spent so much time on it. It's actually awesome, I think.
And can you mention again what increasing the size of the femoral head will do? Because we mentioned before, increasing the size of that femoral head component may increase your offset, but also possibly increase your leg length. And I know it has to do with how many degrees of rotation before you get impingement, or it kind of makes it a little bit more stable. Can we just talk about that?
Sure. And I think an important thing to keep in mind is that there's a difference between increasing the size of the femoral head and increasing the distance or where the femoral head sits on the stem. So as far as size, majority of the time we're doing 36 or 32 millimeter heads. Back in the old days, back when the staff that trained me were doing it, they were doing 22 millimeter heads on total capsulectomies, and they had really high dislocation rates. We kind of realized the bigger head. Once you get above a 28, it's hard to say if there's any difference. But the bigger the femoral head is as far as diameter, the farther range of motion you've got before the neck will start impinging on the cup. When the neck impinges on the cup, that starts to lift the femoral head out of the poly, out of the acetabulum, and that's where your dislocations come from. But as far as the plus sizes, like we always say, 36 plus 1.5, 36.5, the plus or minus is how far the femoral head or the ball that you put on sits up on the femoral component. So the higher the plus numbers is, majority of the time that will increase your offset and increase your leg length, and both of those things will improve your stability, which is why if we're doing a trial in the operating room and somebody's not quite as stable as we want it, say a 0, we might try a plus 2.5, and all of a sudden it makes them a little bit more stable because we've increased their offset and increased their leg length. Both things help tighten the soft tissue and make them a little more stable.
Yeah. And this is why you want to get as many of these cases down as you can, because it can be confusing, but I think the more you do it, the better, the more understanding it you get with these types, just the language that we're using. So, okay, let's say we've done our template and we have us a game plan going into the OR.